If you stopped right now and considered the entire population of the planet, that's what, around 7 billion people,
Mhm.
how many of them, realistically, do you think have reliable access to safe and affordable surgery? And I'm not talking about, elective procedures. I mean the foundational stuff, the
Mhm.
life-saving necessities, setting a complex fracture, performing a trauma laparotomy, or managing an obstructed labor with a C-section.
Well, the answer, it's pretty devastating, actually, and it really sets the stage for our whole deep dive today. You look at the core data, the stuff from the Lancet Commission on Global Surgery.
The 2015 report.
That's the one, foundational work. And they found that 5 billion people, I mean, that's just the vast majority of everyone on the planet. They just don't have access to safe, affordable surgical care when they need it.
5 billion. Wow. That number isn't just a statistic, is it? It feels like. Well, like a global public health failure on a scale that's hard to comprehend.
It absolutely is,
Yeah.
which is why we're dedicating this entire conversation today to really uh, executing a detailed examination of Chapter 16, Global Health and Surgery,
Yeah.
from Bailey and Love's Short Practice of Surgery.
Right. A classic text, and this chapter is crucial.
Exactly. Our mission here is pretty laser-focused. We want to distill every key concept, every actionable insight, every essential metric from this chapter. The goal is to provide you, the listener, with that robust, synthesized knowledge you need for, well, for serious revision, for professional practice, and honestly, just for being truly well-informed about the challenges and, importantly, the solutions in this field.
So we're taking that huge 5 billion gap, the one quantified back in 2015, and we're moving beyond just the shock value. We want to understand the definitions, the economics, the strategies needed to actually bridge this immense chasm.
Precisely. Because that statistic, that 5 billion number, it immediately elevates surgery, doesn't it? From something that may be perceived as a specialist luxury.
To what it truly is, an indispensable core component of essential public health infrastructure. You can't have universal health coverage without it.
You really can't. If we fail to address this, we are failing 5 billion people. Simple as that.
Okay, let's unpack this. Before we dive deep into the economics and the access issues, we really need to be crystal clear on the terminology. When we talk about global health versus global surgery, what's the precise distinction there? Because they sound similar, but they're not quite the same.
No, they're not quite the same, and it's vital we get this right from the start. So global health, in its broadest sense, is really about the health of populations, but specifically in a global context. It deals with those big population-level health problems. Think communicable diseases, non-communicable diseases, injuries that inherently, they cross national borders. They require international collaboration to solve.
Okay, so that's the big picture. Global surgery, then, takes that population perspective, but applies it specifically to surgical care.
Exactly. And this is the key bit with a crucial public health lens. The definition used is surgery with an understanding of public health. And historically, you pointed this out, that hasn't really been the standard approach for surgeons, has it?
Not really. A surgeon's training, quite rightly, focuses intensely on the individual patient right there in front of them. It's a micro-focus, isn't it? Managing the trauma, the obstruction, the tumor in that one person.
Right. It has to be. But public health forces you to think differently. It forces an understanding of the scope and the sheer volume of surgical operations needed across the entire population. That's the macro focus. Global surgery is where these two meet. Is that necessary integration point, merging the technical skill of surgery with the population-level strategy of public health. And the aim, achieving equitable surgical care for everyone, everywhere.
The source material uses a really helpful analogy here to kind of hammer this home. The retailer versus the wholesaler. I found that quite clarifying.
It's an excellent distinction, yeah. So imagine a practicing surgeon in an operating room, meticulously doing a procedure for their specific patient. That surgeon is the retailer.
Okay. Addressing the immediate specific need of one person who managed to get through the system to reach them.
Exactly. The global surgeon, however, has to step back and take a much broader view. They're acting as the wholesaler of surgical needs for a whole population. Their specialty isn't necessarily just, say, cardiothoracic surgery or neurosurgery. Their specialty is focused on providing the entire suite of essential surgical care that their community actually needs, based on the real burden of surgical disease in that specific area.
So it implies a need for more generalist skills, perhaps, especially at the district level.
Often, yes, especially at the district hospital level, where the need is often greatest and resources are most limited. A global surgeon there needs to be competent in trauma, obstetrics, basic general surgery, the essentials, They're specialized in providing what the population needs most to cut down mortality and disability. It's not always about the most technically complex, subspecialized procedure.
And this framing directly challenges that common misconception we talked about.
Yeah.
The idea that global surgery just means a surgeon from a high-income country, an HIC,
Right.
flying into a low or middle-income country, an LMIC, for a couple of weeks on a mission trip.
Yeah, right. That picture.
And that's the conception we really have to dismantle. Look, those missions have a history, and some have done good work, but they fundamentally cannot address the core problem. A mission trip, by its very nature, it's temporary. It's a drop in the ocean compared to the vast, overwhelming systemic burden of surgical disease in LMICs, which is their 247, 365 days a year. So it's shifting from thinking about short-term charity interventions to long-term sustainable systems engineering. Is that a fair way to put it?
That's a perfect way to put it. The absolute foundational principle of global surgery is that the focus must be on improving surgical health systems locally. And critically, this has to be led and owned by local surgeons, local healthcare providers in the communities that actually bear the highest burden of disease.
So where do HIC surgeons fit in then? Is there still a role?
Oh, absolutely, a vital role. But it needs to shift. Less focus on direct short-term intervention and much more on sustained institutional partnerships, on capacity building, on supporting long-term training programs.
And when you look at why those short-term interventions often fall short, the critiques mentioned in the source are pretty strong. Things like drawing resources away from local providers.
Exactly, or lacking reliable postoperative follow-up, which is crucial for safety.
And even inadvertently creating a perception that the external care is somehow better, which can undermine the development of local capacity and, just as importantly, local confidence.
That hits the nail on the head. It all comes back to sustainability. The only way we're going to solve this 5 billion person problem is by strengthening the LMIC health system from within. We need to ensure the local infrastructure, the training pipeline, the supply chains, all of it can reliably deliver care day in, day out. That reframing from quick fixes to systemic solutions, that's the essential mental shift you need to make sense of global surgery.
Okay, so we understand the what. Now let's tackle the why. Why should surgery be a public health priority at all? Because, as you mentioned, for decades, it was kind of dismissed in global health circles. It was seen as too complicated, too resource-intensive, maybe just too expensive for places with limited resources. What actually changed that perception so dramatically?
Well, it boils down to the data, irrefutable data. Specifically, this big epidemiological shift that's been observed globally over the last, say, 20 years or so. We've had these incredible, truly transformative successes in reducing the burden of communicable diseases, things like HIV, malaria, TB, massive global efforts with vaccines, drugs, sanitation.
And they worked, largely. But as those burdens successfully declined, what started taking their place?
Non-communicable diseases, or NCDs, and injuries. That's what rose to the top. Today, roughly one-third, a full third of the total disease burden worldwide is directly due to conditions that need surgical care. And this is primarily injuries. Road traffic accidents are a huge one, and cancers. With NCDs and trauma rising sharply, especially in LMICs that are rapidly developing and urbanizing, the surgical disease burden just became, well, too large and too deadly to ignore any longer.
So the sheer scale of the problem forced a recognition. And that culminated in a major policy milestone around 2015, didn't it?
Yes, exactly. The 2015 World Health Assembly, that's the big annual meeting of all the world's health ministers, they formally declared surgery and anesthesia care an indispensable part of public health. That was huge, a monumental policy shift. It essentially gave the green light, the political backing, for national health planners everywhere to start integrating surgery into their core essential services packages.
And the driver wasn't just humanitarian concern, was it? There was a powerful economic argument emerging, too. The evidence started showing that providing timely surgical care isn't just an expense, it's actually an investment.
Absolutely. And the source material really emphasizes this economic proof, particularly highlighting the work done by the World Bank's Disease Control Priorities Group, the DCP. They identified these specific, common, often easily treatable surgical conditions where, if you neglect them, it doesn't just result in individual suffering, death, or disability. It leads to massive lifetime costs for the individual, for their family, and for society as a whole.
What are some of those key conditions, the ones where timely investment really pays off?
We're talking about things that should be relatively routine, right? Acute appendicitis, if you delay that, you get peritonitis, sepsis, much worse outcomes, much higher costs. Hernias, they get incarcerated or strangulated, needing far more complex, resource-heavy operations.
Yeah.
Major fractures, if not treated properly, lead to permanent disability, loss of productivity, obstructed labor, a tragedy risking 2 lives, mother and baby. And common manageable cancers like breast and cervical cancer, they become advanced and untreatable if not caught and dealt with early. Neglecting these is just economically ruinous in the long run.
Okay, here's where it gets really interesting, because the real power of the argument seems to come from the cost-effectiveness comparisons. This is where the data elevates surgery beyond just, doing good to being sound financial policy. It puts it right alongside the most proven public health measures.
The comparative data is pretty stunning, yeah. Think about interventions that are universally accepted as highly effective, like the BCG vaccine for tuberculosis. Massively important. Well, it turns out that surgical interventions for conditions like cataracts, restoring sight, restoring productivity, or hydrocephalus in children, saving cognitive function, or correcting limb deformities, repairing cleft lips and palates, their cost-effectiveness is directly comparable to BCG.
Directly comparable. And the source even suggests often greater cost-effectiveness than other standard high-profile measures, like providing antiretroviral therapy, ART for HIV patients.
Yes, in many cases, the data points that way. And that completely changes the calculation for global health resource allocation, doesn't it? When policymakers are looking at metrics like disability-adjusted life years or DALYs, averted per dollar spent, surgical interventions often come out looking incredibly efficient.
Remind us quickly, a DALY is basically a measure of lost years of healthy life, right? Due to premature death or living with disability.
Exactly. So by preventing disability, say, correcting a clubfoot so a child can walk, or removing a cataract so someone can see and work again, surgery restores potentially decades of productivity and quality of life, and often at a relatively low cost compared to, say, the lifetime management of a chronic illness that wasn't prevented.
So if a cataract operation costs relatively little but gives someone back 20 years of sight and work, the economic return in DALYs averted is just immense. That comparison is crucial for the global health planner trying to allocate scarce resources.
It really is. It forces planners to see surgical interventions not as a luxury add-on, but as a highly efficient way to avert both death and long-term disability. But there's a really crucial nuance here about efficiency that the source material points out. Surgery is most cost-effective when it's not just performed as sort of isolated ad hoc procedures here and there.
Right. It needs to be delivered systematically, as a group of interventions within a reliable functional platform of clinical care, often centered around something like a district hospital.
That's the key. That platform approach maximizes efficiency because you're leveraging shared resources, the staffing, the sterilization capacity, the blood bank, imaging, the supply chains. They support multiple needs at once. You don't just build a facility for C-sections, you invest in a system that can handle C-sections and epidectomies and trauma and hernia repairs. That maximizes the return on investment and ensures integrated safe care for a whole population. So the economic case is pretty much settled. Now we really have to confront the structure of the access crisis itself.
Okay, let's circle back then to that central defining crisis statistic from the 2015 Lancet Commission. 5 billion people lack access to surgery. The source material really stresses that access to timely, life-saving essential surgery isn't a bonus, it's a fundamental human need. But access itself isn't just about whether there's a hospital building nearby, is it? It's actually far more complex than that.
It is, far more. You can't just count operating rooms and call it a day. Access to safe and affordable surgery, as defined in the literature, is measured as a joint probability. What that means is access is only truly achieved if a patient can successfully clear 4 distinct sequential hurdles all at the same time. If any one of these conditions fails, the whole system fails for that patient. Access fails.
Right, these are the 4 dimensions of access. I think they use the acronym TCSA, detailed in figure 16.1 in the chapter. Let's break those down. What's the first hurdle?
The first is timeliness, T. This is simply the ability to actually receive care within the crucial time window that the specific condition dictates. For really time-critical stuff like a massive hemorrhage or major trauma, that window might be incredibly short, maybe just 2 hours. Failure of timeliness usually comes down to geographical barriers.
Things like poor roads, no reliable transport, or just the sheer distance to the nearest facility that can actually do surgery.
Exactly. If you live 10 hours away from the nearest district hospital that has a surgeon, timely care for an emergency is basically impossible, which links directly to that concept of geographical access, often defined as reaching a surgical facility within that 2-hour window.
Okay, so hurdle 1 is getting there fast enough. What's the second?
The second is capacity. So, okay, the patient makes it to the facility on time. Great. But does the facility actually have the necessary capacity to do the work? This includes the physical infrastructure, reliable electricity, clean running water, working sterilization equipment, essential drugs and supplies, and, crucially, the required workforce. Do they have the surgeon, the anesthetist, the obstetrician, the nurses, the SAU team we'll talk more about? Capacity often fails because of chronic staff shortages or maybe intermittent infrastructure problems. The power goes out, the sterilizer breaks down, the blood bank fridge fails.
That sounds like a really common failure point in resource-limited settings. A skilled surgeon might even be there, but if the lights don't work reliably or there are no sterile gloves, capacity is effectively zero.
Precisely. Hurdle 3 is safety. Assess. Assuming they get there on time and the capacity exists, is the procedure itself actually going to be safe? Safety covers everything from adhering to basic protocols, proper anesthesia monitoring, effective infection control measures preventing those dreaded surgical site infections, right through to decent postoperative care. Failure here often means the patient survives the operation itself, but dies afterwards from a complication. That completely undermines trust in the whole system.
So access has to be safe access. It's non-negotiable.
Absolutely. And then the final hurdle, often the most heartbreaking one, affordability, A. The patient or their family must actually be able to afford the procedure without being pushed into financial ruin. As we'll discuss in more detail later, this is the barrier that tragically stops millions of people who might have successfully navigated the first 3 hurdles. If you can't pay, you often don't get the care.
And the consequence of failing at any one of these 4 points, timeliness, capacity, safety, or affordability, is just devastating. The source says 9 out of 10 people in LMICs lack this comprehensive access, which leads to patients arriving too late, not just delayed by a few hours, but presenting with conditions that are now way more advanced, much harder, and more resource-intensive to treat, if they're even treatable at all by that point.
Exactly.
Yeah.
We see patients coming in with advanced cancers that maybe could have been cured if caught earlier. Severely infected open fractures that now require amputation instead of limb salvage. Perforated bowels that have progressed to overwhelming sepsis. Or kids with burn contractures that have solidified over months or years into permanent disabling deformities. The level of preventable suffering is just immense.
Which brings us back to the sheer scale of the unmet need globally. How does that translate into the actual number of operations the world needs to be doing?
Well, the estimate is that the world currently needs to perform 143 million more surgical operations every single year, just to save lives and prevent disability from conditions that are treatable by surgery.
143 million more, on top of what's already being done.
On top of what's already being done, globally, the surgical community performs around 313 million procedures each year. So it's a massive shortfall, almost a 50% increase needed. But the real issue isn't just the total number, it's the distribution.
Right, the imbalance is staggering. The source highlights that only about 6% of those 313 million procedures are done in the poorest countries.
Only 6%. Yet those same countries are home to over a third of the entire global population.
That's the core maldistribution, isn't it?
It is. The unmet need is incredibly concentrated in specific regions, Eastern, Western, and Central Sub-Saharan Africa, and also South Asia. And this imbalance leads directly to those tragic, avoidable outcomes we keep mentioning, like young mothers dying in childbirth simply for want of a timely cesarean section. It happens every day.
So to try and combat this, the global surgical community has actually set some concrete operational volume goals for 2030, giving us a measurable target to aim for.
Yes, there's a target. The goal is to reach an optimum operative volume of 5,000 surgical procedures per 100,000 population across the world by the year 2030. This benchmark isn't just pulled out of thin air. It's based on modeling and looking at empirical evidence about the volume of surgery required to handle the essential, life-saving burden of disease in a typical population.
Why 5,000 specifically? What happens if you go much higher? The source mentions Hungary, for example, performing something like 23,000 operations per 100,000. Is more always better?
That's a really crucial question. Is more always better? And the evidence suggests, not necessarily in terms of broad population health outcomes. The 5,000 threshold seems to represent the point where a population achieves enough surgical capacity to manage the vast majority of its time-sensitive needs, trauma, obstetrics, acute general surgery, plus the essential cancer care and chronic condition management. The data indicates that pushing expenditure and operative volumes much higher than 5,000 doesn't bring a proportional health benefit across the whole population. You might be doing more elective procedures, maybe more minor things, but the impact on overall mortality and morbidity seems to plateau.
So 5,000 is kind of the efficient, necessary target for essential coverage. But the current gap between that target and reality in many places is terrifying. You mentioned Ethiopia earlier, performing only 150 operations per 100,000.
Yeah, 150 versus a target of 5,000. The chasm is just extreme, and the cost of staying so far below that target is incredibly high. Low operative volumes, like 150, are consistently associated with much higher case fatality rates, even for common treatable conditions. A system stretched that thin just can't provide safe care consistently. Complications and deaths are inevitably exponentially higher than they should be.
Okay, so if the goal is 5,000 procedures per 100,000 people, that immediately slams us into the next bottleneck, staffing. Who is actually going to do all this work? The whole system seems to rest on the shoulders of three essential types of providers.
That's right. The critical core unit, particularly when you're thinking about the district hospital level, which is key for access, is the trio, the surgeon, the anesthetist, and the obstetrician. Yeah, the SAO team. The density of these SAO providers per 100,000 population becomes our key metric for measuring surgical workforce capacity.
And in many, many LMICs, that metric is alarmingly low, as the source points out.
Alarmingly low is right. Many countries are currently operating with fewer than 5 SAOs per 100,000 people, sometimes much lower. But the good news is, the correlation between increasing that SAO density and seeing positive health outcomes is really strong and undeniable. As the number of SAOs goes up, you see dramatic improvements in key population health indicators, maybe most notably, a significant reduction in the maternal mortality ratio.
And just like with the operative volume target of 5,000, there seems to be an efficiency threshold for the workforce, too. You don't need infinite numbers.
Exactly. The positive health benefits, while strong initially, tend to plateau once you get beyond about 20 SAOs per 100,000 population. Therefore, the global commitment, the target everyone is aiming for by 2030, is for all LMICs to scale up their surgical workforce to reach at least that level, 20 SAO providers per 100,000 population.
20. So 5,000 procedures and 20 SAOs per 100K. Those are the magic numbers for 2030. What does hitting that workforce target actually demand globally in terms of training new people? It's huge. To hit that 20 per 100,000 benchmark across all LMICs, the estimate is that globally, 1.27 million new SAO providers will need to be trained by 2030.
1.27 million. That's a massive educational and logistical undertaking.
It is. And given the existing staff shortages and the urgency of the problem, you can't just wait for traditional long residency programs to fill that gap entirely. It necessitates using strategies like task shifting.
Okay, task shifting. Define that for us again. It basically means moving appropriate surgical or anesthetic tasks to health workers who are less specialized, specifically where there just aren't enough specialists available.
That's the core idea, yes.
Now, for a specialized audience, like many of our listeners, this immediately raises questions, doesn't it? Practical questions, ethical questions, questions about safety. How is task shifting actually implemented effectively and safely, especially in resource-poor settings? It's a really important question. Task shifting isn't just, letting anyone have a go. It has to be implemented based on rigorous, competency-based training for specific, often life-saving procedures. For instance, in places with severe shortages of specialist anesthetists, essential life-saving anesthesia techniques, often quite simple, safe methods for common surgeries like C-sections or fracture fixation, are taught through focused, intensive short courses to general medical graduates or even clinical officers in some settings. These aren't full specialist qualifications, obviously, but they provide high-impact training to manage specific common emergencies safely when no specialist is available.
And in the most resource-poor settings, the source indicates the need is so profound that task shifting can extend even further, maybe involving non-medically qualified clinicians.
Yes, in some very resource-constrained environments, appropriately trained non-physician clinicians like experienced clinical officers, surgical technicians, or even specially trained midwives are involved in providing anesthesia or performing highly specific, essential surgical procedures like C-sections or hernia repairs. The evidence, when it's done well, actually supports this practice where specialists are unavailable. The key provisos are intensive, focused training, ongoing supportive supervision, and ensuring everyone functions within very clearly defined scopes of practice. It's really a pragmatic response to a crisis where the only alternative is often no care at all, which usually means death or severe disability.
But even if we manage to train this huge number, 1.27 million new providers through traditional routes and task shifting, We run straight into that paradox of distribution, don't we? Where will these newly trained people actually practice?
That is the absolute core challenge. The irony, as the source points out, is just stark. You have countries, often HICs, with the lowest birth rates and maybe lower burdens of certain surgical diseases, yet they have a relative oversupply of some subspecialists like pediatric surgeons. Meanwhile, in high-burden LMICs, you might find a single, incredibly dedicated global surgical champion trying to cover the surgical needs of literally millions of people across a vast geographic area.
That model of extreme isolation and crushing workload, it's just completely unsustainable, isn't it? It inevitably leads to professional burnout and critically migration. The brain drain.
The brain drain is a huge factor, and it's quantified quite clearly in our source material. Around 12%, think about that, 12% of the surgeons, anesthetists, and obstetricians currently practicing in high-income countries actually graduated from medical schools in low- or middle-income countries. And even more worryingly, about 2/3 of those migrating SAO graduates are coming from the very countries that currently have fewer than 20 SAOs per 100,000 population. They are leaving the systems that desperately need them most to reach that 2030 benchmark.
So the realization is pretty profound, isn't it? Simply training more people, throwing more numbers at the problem, is like pouring water into a leaky bucket if we don't fix the underlying issues of maldistribution within countries and this massive international migration. What are the specific systemic solutions proposed in the chapter to try and support and, crucially, retain these vital providers in the health systems where they're most needed?
Yeah, the solutions have to move beyond just train more people. They have to focus on system support, professional development, and frankly, professional dignity and quality of life. One key strategy is anchoring global surgery efforts within academic institutions, starting dedicated global surgery units or programs within teaching universities in LMICs. This provides a strong research base, an academic home, and helps elevate the status of the field. And crucially, technology plays a massive role in combating that professional isolation we talked about.
How specifically can technology help fight isolation and burnout for surgeons working in remote or under-resourced areas?
Well, primarily by providing continuous professional connectivity and support. Think about things like using technology for e-grand rounds, where specialists in urban centers or even internationally can share knowledge and discuss complex cases remotely with colleagues in district hospitals. It involves implementing remote special support through systems like e-intensive care units or EICUs, allowing expert critical care consultation on really sick patients who might be thousands of miles away. And furthermore, investing in things like low-cost robotics for certain procedures, using digital simulation for training, and making high-quality online learning platforms readily available. All of this helps local surgeons feel connected to global standards of practice, allows them to continuously upgrade their skills without having to leave their post for long periods.
And beyond the hard technology, you also mentioned the soft interventions, things like support and recognition. Those sound crucial too.
They are perhaps the most vital.
Yeah.
The systemic support needs to include proper supportive supervision, which means mentorship and collegiality, not just punitive inspection. It means genuine recognition of the often heroic efforts these providers are making. And it means ensuring they have acceptable working conditions, reasonable workloads where possible, and decent living conditions for themselves and their families. A single surgeon trying to cater to millions cannot do it alone. They must be supported by a robust, multidisciplinary team.
Right, because the surgical ecosystem is vast. It's not just the SAO trio working in isolation.
Not at all. The source material really stresses the absolute necessity of involving everyone. Other physicians, skilled nurses, who are critical, public health practitioners, efficient hospital managers, laboratory specialists, supply chain experts who make sure the gear is there, biomedical engineers to fix equipment, radiology technicians, blood bank technicians. The list goes on. And particularly in high-burden LMICs, you cannot underestimate the vital role of the community health worker at the front end, helping to reduce diagnostic delays, educating communities, and facilitating appropriate referral pathways so patients actually get to the surgical facility when they need to.
And one final piece of the workforce puzzle mentioned is the private sector. How do they fit in?
Yeah, we can't ignore them. Private practitioners are often a significant source of surgical manpower in many LMICs. They need to be recognized and engaged as part of the solution. If they're appropriately incentivized and, importantly, regulated to ensure quality, safety, and ethical practice, they can definitely contribute significantly to achieving those 2030 surgical goals. especially in providing planned surgical care and helping to expand geographic coverage into underserved areas.
Okay, we've covered the clinical need, the public health arguments, the workforce crisis. Now we really have to confront what is arguably the most heartbreaking consequence of this whole access gap: the direct link between lacking surgical access and pushing already vulnerable families into abject poverty.
This is where the failure to provide timely care doesn't just cause a health problem, it triggers a catastrophic financial disaster for households. We talked about the clinical costs of delay. The C-section doesn't happen, the mother dies, the hernia isn't fixed promptly, it incarcerates, needing a much bigger operation, longer hospital stay, more lost wages.
But the specific term used to measure the impact on families is catastrophic expenditure. Can you define that again for our listener? Because it's such a critical metric for understanding poverty risk related to health costs.
Right. Catastrophic health expenditure is formally defined as out-of-pocket health, spending the money a family has to pay directly that exceeds a certain threshold of their household income, often 40%, after accounting for basic subsistence needs like food and shelter. So when an unexpected major operation is needed, think about a severe injury from a road accident needing multiple surgeries or complex fracture fixation. The sheer cost of the procedure itself, plus the supplies, the drugs, the postoperative care, and you have to add in the lost wages for the patient and often for family members who have to provide care. It can instantly push a household that was just getting by into total financial ruin.
And the statistics cited in the source on this are just staggering. They really illustrate the scale of human misery caused by this.
They absolutely do. It's terrifying. The estimate is that 44% of the world's population, almost half of humanity, is currently at risk of suffering financial catastrophe from the cost of just a single major operative procedure. And when you look at the annual impact, it's estimated that 33 million people are pushed into poverty every single year simply by having to pay for the surgery and anesthesia that they desperately needed.
33 million. Just to put that in perspective, the source notes that's more than the entire population of Australia pushed into poverty each year.
By healthcare costs.
Exactly. And falling into that level of poverty isn't temporary. It often means selling essential assets like land or livestock, pulling children out of school, sacrificing the ability to afford nutritious food. It traps entire families, entire generations.
It creates this vicious intergenerational cycle of surgical poverty. It does. And the risk isn't spread evenly either. The risk of hitting that catastrophic expenditure threshold is greatest for conditions that are time critical. Things like acute peritonitis from a burst appendix or severe burns. These conditions demand immediate intervention. There's no time to save up or borrow money gradually or make a plan. The frequent requirement for immediate upfront payment before treatment even starts. It effectively becomes a death sentence for those who can't afford it.
The source makes an interesting point here that surgeons themselves, may be understandably focused on the intense technical complexity inside the operating theater, have sometimes been a bit disconnected from these harsh socioeconomic realities that determine whether their patient ever even makes it through the hospital doors.
I think that's fair, and it's part of the problem that the global surgery movement is trying to address. Surgeons need to be aware of these barriers. If payment is required up front, the hard reality in many places is that those who cannot afford to pay simply don't get the surgery. Or perhaps they delay seeking care until they've scraped money together, by which time they arrive so late that the complication rate skyrockets and the cost potentially goes up even further. This perception that surgery is inherently an expensive, specialized business, often reinforced by these direct out-of-pocket payment systems, drives this tragic exclusion.
And when you look at these costs, not just at the family level, but aggregate them nationally, the situation looks even more dire, doesn't it? The source mentions that the total national out-of-pocket expenses just for injury care alone.
Just injury care, things like road traffic injuries, falls, burns, violence.
It can actually exceed the total annual health budget of many low-income countries.
It's unbelievable, but true. It just highlights the extreme strain these costs place on already fragile public systems, let alone on individual families. And the tragic, predictable outcome is that far too often, it's only the wealthiest segments of the population, maybe the top 10 or 20%, the upper wealth quintiles, who are consistently privileged enough to access necessary surgery, even when that surgery is deemed essential and life-saving by any medical standard. For the vast majority, this fundamental health service remains effectively out of reach purely because of the financial barrier.
Okay, so if we accept that this is a massive population-level problem, it follows that you have to measure it at the population level too. Surgeons are obviously very good at tracking traditional hospital-based metrics, things like surgical site infection rates, post-op ventilation times, mortality within the hospital. But global surgery seems to demand a major expansion of focus right into the realm of public health epidemiology, looking beyond the hospital walls.
Absolutely.
Mm.
You can't manage what you don't measure, especially at a population scale. Global surgery absolutely demands adding robust population-level metrics to our toolkit. We need these to truly understand the actual burden of surgical disease out there in the community and to assess how well the entire national health system is functioning or not functioning in getting people the care they need. We have to know who is getting sick or injured, who is dying from treatable conditions, and why aren't they getting the care they need long before they ever reach or fail to reach the hospital doors.
So, what are some examples of the data sources or methods used to capture these population-level metrics, especially in settings where routine hospital record keeping might be incomplete or unreliable? Well, we often have to rely on more sophisticated surveillance systems and sometimes large-scale population surveys. For example, you might use specific household-level surveys designed to assess the community burden of injuries, how many people got injured, what type did they seek care, or surveys looking at vision care needs or cancer screening uptake. On a broader epidemiological tracking level, we use metrics like the National Maternal Mortality Ratio, which is actually a very powerful proxy indicator for the strength of a country's entire surgical and obstetric system. Or looking at things like cesarean section rates, are they too low, suggesting unmet need, or sometimes too high in certain facilities, suggesting overuse. And the source also mentions leveraging things like demographic surveillance systems, where they track populations closely over time, or large-scale studies like the Million Death Study in India, which use verbal autopsies to try and assess causes of death, including things like acute abdominal disorders at a national level.
Exactly. All this epidemiological data is absolutely essential for doing those cost-effectiveness calculations we talked about earlier, using DALYs, the disability-adjusted life years averted. Remember, DALYs are the common currency of public health. By quantifying how much it costs, on average, to avert 1 year of suffering, either death or disability, policymakers can make more objective comparisons. They can ask, is spending $100 on cataract surgery a better population investment than spending $100 on, say, a new vaccination program based on the DALYs gained per dollar?
And that daily analysis consistently reinforces the urgency of this problem, doesn't it? Circling back to that shocking statistic, 1/3 of all deaths worldwide are ultimately the result of conditions needing surgical care.
1/3. It's a staggering figure, and as the source notes, that surpasses the combined mortality burden of HIV, malaria, and tuberculosis. When you see numbers like that, it just makes the inclusion of surgery in core public health planning a complete non-negotiable imperative,
Hmm.
based purely on the sheer burden of disease.
Okay, let's turn now to the concrete indicators that are actually used to monitor progress towards that global goal of universal access. The source material details 5 core indicators. These are like the annual report card for global surgery progress in a country.
That's a good way to think of it. These 5 core indicators are designed to monitor progress towards achieving universal access to safe, affordable surgical and anesthesia care. They're generally categorized into 3 main domains: preparedness, surgical service delivery, and affordability.
All right, let's start with preparedness.
Yeah.
This seems to focus on having the basic access and capacity in place.
Correct. The first indicator under preparedness is access to timely essential surgery. This is measured specifically as the percentage of the population living within a 2-hour travel time radius of a facility that can reliably perform a set of essential bellwether procedures. We'll define those in a moment. The second preparedness indicator is the one we discussed earlier: the density of SAOs, surgeons, anesthetists, and obstetricians per 100,000 population, tracking progress towards that target of 20.
Okay, so preparedness is about having the potential, reachability, and staffing. Next is surgical service delivery. This sounds like it measures actual volume and safety.
Exactly. The third indicator is the volume of procedures done in an operating theater per 100,000 population per year. This tracks the actual utilization of surgical services against that 5,000 target volume we talked about. Are people actually getting the surgeries? And the fourth indicator is a crucial safety metric: the perioperative mortality rate, often measured as the all-cause death rate before discharge for patients who undergo any procedure in an operating theater, calculated against the total number of procedures performed. How safe is the surgery that is being done?
Got it. Volume and safety. And finally, the third domain, affordability. This tackles that financial barrier head on.
Yes. The fifth indicator directly addresses the economic burden. It tracks the proportion of households protected against impoverishment and catastrophic expenditure, resulting from direct out-of-pocket payments for surgical and anesthesia care. Are people being bankrupted by needing surgery? If a country shows positive progress across all 5 of these metrics, it's a strong sign that they are genuinely moving towards achieving universal health coverage, or UHC, for surgical care.
Now let's talk about the actual delivery platform. We know we need to decentralize care to meet this vast need, especially in resource-poor settings. How does that work in practice?
Well, the WHO has identified a list of 44 essential surgical procedures. And the really critical finding is that 29 of those 44, the majority, can be safely and effectively performed at a well-functioning district hospital level. This really emphasizes the point that essential life-saving surgical care doesn't always require a big, sophisticated tertiary referral center in the capital city. Much of it can and should happen closer to where people live.
And to gauge whether that district-level system is actually functional enough to provide that care, the source highlights the use of Bellwether procedures. What are these and why are they used as a proxy measure?
Right, the bellwethers. There are 3 key procedures that act as indicators, or bellwethers, for the system's overall ability to perform a much broader range of essential operations safely. Those 3 are cesarean sections, laparotomies, which is basically exploratory abdominal surgery, often needed for trauma or acute infections like appendicitis or perforated ulcers, and the basic surgical treatment of open fractures.
Why those 3 specifically? What makes them such good indicators?
Because successfully and crucially safely performing all 3 of these requires the entire surgical system at that facility to be reasonably functional. You need competent SAO staff available 24/7. You need functioning anesthesia equipment and trained personnel. You need good sterile technique and infection control. You need a reliable blood supply or blood bank. And you need decent post-operative care capabilities. If a district hospital can consistently and safely manage C-sections, laparotomies, and open fractures, it's highly likely they have the core infrastructure and skills needed to handle many of the other 29 essential procedures as well. They serve as a really effective litmus test for essential surgical capacity.
That makes sense. Now, in areas with severe shortages, especially of specialist surgeons, they can't really triage patients based on specialty, can they? They have to prioritize based purely on urgency. The source describes a structured 3-category triage system for this.
Yes, in high-volume, low-resource settings, this kind of urgency-based triage is essential to make sure the limited surgical capacity is always directed towards saving the most lives first. The system categorizes surgical needs into must-do procedures. These are the absolute time-critical emergencies that cannot be delayed beyond 24 hours without risking life or limb. Think major hemorrhage, obstructed airway, impending C-section. Then you have the should-do procedures. These are urgent and need to be done relatively soon, ideally within a week, to prevent significant morbidity or progression, like an uncomplicated appendicitis or draining a large abscess. And finally, the can-do procedures. These are still essential operations, but they can safely wait for more than a week if necessary, allowing prioritization of the more urgent cases. Things like elective hernia repair, which still prevents future complications and catastrophic expenditure, but isn't immediately life-threatening.
That seems like a very practical way to manage overwhelming demand with limited resources. The source material also gives us a clear summary, in Summary Box 16.1, of the recommended core intervention packages for strengthening emergency and essential surgical care nationally. What does this comprehensive package look like for a health system trying to implement UHC for surgery?
These packages really form the building blocks of a comprehensive National Surgical, Obstetric, and Anesthesia Plan, or NSOAP, which countries are encouraged to develop. They're logically categorized into emergency care and planned care. For emergency procedures, the core package needs to include a basic trauma package, focused on resuscitation, managing bleeding, treating basic fractures, wound debridement, a basic obstetric package absolutely centered on having 247 C-section capability, and a basic emergency general surgical package, primarily the ability to perform laparotomies for acute abdominal conditions like perforation, obstruction, or sepsis.
Okay, those cover the immediate life and limb threats. What about the planned care packages? To manage the more chronic conditions and high-volume needs that still cause huge amounts of disability.
Right. The planned care packages are crucial for improving long-term health, productivity, and quality of life. The core recommendations include a general surgical package, covering high-volume needs like hernia repair, perhaps basic bowel resection for tumors, an obstetric and gynecological package, including procedures like hysterectomy for severe hemorrhage or cancer, managing prolapse, a specialist package focused on very high-impact often high-volume procedures, like cataract surgery to restore sight or clubfoot correction in children. And importantly, a palliative surgical package, things like creating a diversion colostomy for obstructing colon cancer, plus ensuring access to effective pain management. Integrating these core packages reliably at the district hospital level is really the key operational strategy to closing that 5,000 operations gap and meeting the population's essential needs.
Finally, in this section, let's touch on collaboration again. We live in an interconnected world, so high-income countries clearly have a role to play. But we established earlier that the model needs to evolve beyond just the traditional short-term mission trip. What does successful, sustainable collaboration look like now?
Well, HICs definitely have critical roles they can play. Things like supporting high-quality research into the burden of surgical disease in LMICs, hosting joint academic grand rounds, which can now easily be done virtually, facilitating structured training fellowships for LMIC surgeons in specialized areas, perhaps. But the clear direction for the future, the most impactful approach, is shifting towards long-term institutional partnerships. Think university to university or hospital to hospital links, rather than just individuals or small teams parachuting in for short stints.
And we should acknowledge the historical contributions of some mission groups, like Operation Smile mentioned in the text, particularly in establishing benchmarks for high-quality protocols, safety standards, and data collection in surgery, especially in specialized areas like pediatric cleft repair. That's valuable legacy.
Absolutely. Those contributions are important and help raise standards. But the critiques of the short-term mission model, the potential for discontinuity of care, pulling resources away from local systems, undermining local confidence, those critiques still need to inform how we structure collaboration moving forward.
So the strategic solution for HIC collaboration needs to be fundamentally rooted in sustainability.
Exactly. It has to be about long-term, truly peer-to-peer institutional partnerships. The focus must be squarely on building local capacity, supporting training, strengthening systems, helping develop local research capabilities. And it has to be built on genuine collegiality and mutual respect.
And it really needs to be emphasized that this should be a two-way street of learning, shouldn't it? The source makes the point that HICs actually have a lot they could learn from innovative systems developed in LMICs, especially around efficiency and cost-effectiveness.
Oh, absolutely. Institutions like the Aravind Eye Institute in India, which is famous globally, have perfected incredibly high volume, remarkably low cost, yet extremely safe cataract surgery. They've done this through industrialized levels of efficiency, task shifting, and amazing cost control. HICs facing their own challenges with rising healthcare costs and access issues can and absolutely should be learning from these kinds of models to improve their own systems and affordability.
So the overall future vision for global surgery seems to require surgeons themselves to fundamentally redefine their role, moving far beyond just the technical work in the operating theater.
I think that's right. It involves academic surgeons and universities partnering much more closely with public health colleagues to develop integrated systems like hub-and-spoke models, where specialists at a central hub hospital provide support and mentorship to teams working in more rural spoke facilities. It means evolving surgical practice itself towards maximizing efficiency, perhaps adopting high-volume, lower-profit models for essential procedures, implementing enhanced recovery after surgery, ERS protocols that are adapted for resource-limited settings, and ensuring that post-discharge follow-up is effectively managed, perhaps by leveraging the community health workforce.
And ultimately, it seems the surgeon needs to expand their traditional technical role to also become a powerful advocate, an advocate for policy change, pushing to ensure that safe, affordable, and equitable surgical care becomes a real political and health priority for everyone, everywhere.
That advocacy role is absolutely crucial. Surgeons have a powerful voice and deep understanding of the consequences of inaction. They need to use it. #tag at outro.
So, what does this all mean? We've done a really thorough deep dive here, digging into the definitions, the economics, the access barriers, the workforce challenges, and the practical delivery of global surgery, pulling all those crucial details and evidence directly from Chapter 16 of Bailey and Love. To wrap up, we really need to leave you, the listener, with the major overarching conclusions that summarize both the scale of the crisis and the path forward, as articulated so powerfully by the Lancet Commission back in 2015.
Yes, these are really the 5 key takeaways that consolidate the urgency of the situation and outline the necessary global response. They're worth repeating.
Okay, first, the sheer scale of the problem. 5 billion people. The overwhelming majority of the human population currently cannot get the safe, affordable surgery they need when they need it.
Second, the massive effort required to fix this. 143 million more surgical procedures are needed globally every single year just to prevent avoidable deaths and disability.
Third, the devastating human cost of inaction, particularly the financial cost. 33 million people are pushed into poverty annually simply because they had to pay for essential surgery and anesthesia.
Fourth, the compelling economic imperative. Investing in surgical systems is not a drain. It is highly cost-effective. It saves lives, yes, but it also actively promotes economic growth by keeping people healthy and productive. It's a rational, vital financial decision for national health planners.
And finally, the fundamental strategic conclusion that underpins everything. Surgical and anesthesia care is not optional, it's not a luxury, it is an indivisible, indispensable part of comprehensive healthcare, and it absolutely must be integrated into national health systems at all levels of development, accessible and affordable for all.
Which brings us right back full circle to that critical workforce challenge we discussed. It really seems like the most critical logistical hurdle to overcome. We need that huge number, 1.27 million new providers by 2030, just to reach the minimum necessary density of 20 SAOs per 100,000 population. We know the benefits kind of plateau around that number, meaning just training even more beyond that isn't necessarily the most efficient solution. And we know that the persistent problems of international brain drain migration, and maybe even more importantly, the inequitable distribution of the workforce within countries, with everyone clustered in cities, are actively undermining this entire global effort.
Right. Which leaves us, and you, the listener, with a final provocative thought to consider, building on everything we've discussed from the source material. Given that the population health benefits of SAO density seem to plateau around that 20 per 100,000 mark, and knowing that simply training more people alone won't solve the brain drain or the in-country maldistribution problem, what single policy measure or maybe bundle of measures thinking beyond just new technology or increasing training school capacity do you think is most critical, most likely to actually encourage the retention and, crucially, the equitable in-country distribution of those 1.27 million essential providers needed by 2030, especially getting them to practice outside the major cities?
Is the answer primarily about massive investment in rural infrastructure, better roads, reliable power, maybe high-quality schooling options for their children to make rural life more attractive? Is it something more direct, like mandatory periods of government service in underserved areas linked to specialist training opportunities? Or does the real solution lie even deeper, requiring systemic non-health sector reforms, economic development, security, governance, to make living and working in these underserved rural or remote areas professionally rewarding and personally viable for highly skilled professionals in the long term? Finding the most effective, politically feasible answer to that question. That might just be the ultimate key to finally closing the 5 billion access gap.